I'm amazed that such an innovating scientist doing transplants and gene therapies is for such an old therapy, where now in current treatments and future treatments and anti-VEGFs is the way to go. And of course, you are slightly out of subject, my friend. You are still using injection. It's a combination therapy. So what I'm doing, you are doing, but I'm not doing the laser. So we all know about the theory of VEGF as a key factor in macular edema and neovascular changes. I'm not going to go through that. You all know about that. But let's look at the evidence again. Even before the era of the protocol S and the clarity, which I'm going to show in a minute, we had more studies, randomized control trials, small ones, but we did have 2 meta-analyses about those. You can see it here. And what they showed is that, yes, combination therapy. So if you combine the retinal laser, pan-retinal photocoagulation, with Lucentis or Avastin, then you may have better outcomes. So the laser on its own is not as good as a combination. So once you put the anti-VEGF, things get better. And what they also showed that they proved for the first time, and so did the protocol S, that you have more edema when you're doing laser pan-retinal photocoagulation. This aggravates edema on the diabetics. And you have to put ranibizumab to make things better before you do the laser. And of course, I had some evidence, although not very strong, that if you compare the Avastin versus the retinal photocoagulation, pan-retinal photocoagulation, things may get anatomically at least better. So the questions still remain until the protocol S. And remember, this is not driven by the industry, okay? So this was the randomized Lucentis versus the laser pan-retinal photocoagulation for proliferative disease with or without edema. And with the group, the subgroup of the laser, the ones who had edema had a combined therapy, as they mentioned already. So these are the visual results. You've seen that. That's the overall. And you've seen that it's a profound, statistically and clinically significant difference between the two when you have a macular edema as well as the pan-retinal photocoagulation. Favors the monotherapy. And the ones who didn't have edema to begin with, what it proved that the laser is what we know from the other studies creates more edema. You can see it here, okay? Of course, both can control the disease in an equal manner. You know that from the other previous studies. But of course, he mentioned the vitrectomies. So he mentioned what I want to mention, basically. And he's right. He's pro monotherapy as well. He doesn't know it. More vitrectomies. And of course, the main point, more destruction of the visual field with the laser, pan-retinal photocoagulation, is something which we've been speculating for ages, and now it's proven. But the clarity study is aflibercept versus PRP, so pretty much the same results. More destruction in the field, more macular edema. Same things for Eylea. So let's summarize. Monotherapy is more effective anatomically and functionally. With or without edema, it gives you better visual results. It decreases the probability of developing macular edema, less field destruction, fewer vitrectomies, faster regression of the disease. This may be very important. You've got vitreous hemorrhages and NVIs and all these things. It regresses the disease much faster. And you can treat with one treatment 2 different, or maybe more than 2 different things. So what are the theoretical advantages of the PRP? He's already mentioned. Often long-lasting effects require no additional treatment. Is that true? Well, he's already mentioned that half of the patients did require more than 2 treatments, and some of them did require other treatments, like laser for the macular edema. May cost less than multiple ranibizumab injections. Is that true? Well, a recent publication is telling us that monotherapy is more cost-effective for PDR with DME, 2017. No risk of endophthalmitis and the exposure and the side effects. Well, these are all very insignificant, and he knows that, and you know that already. And it does not apply, as I've already said. You are using anti-VEGF as well, okay? So we're carrying the same risk. Modern ways of lighter type of laser may be okay, but we're still lacking the evidence. We're still concerned about visual field loss. So all these are dropped. No advantages. Sorry about that. That's the way it is. It's the future. But what we know is that we've got more DME, diabetic macular edema with the laser, more damage in the visual fields, more contrast sensitivity problems, more vitrectomies. The list goes on and on. Much slower control of the diabetic retinopathy. It's less cost effective and all this. So in conclusion, we've got the good therapy. Anti-VEGF is an effective, much more effective and safer treatment, and is preferred for at least the patients who've got diabetic proliferative disease with macular edema, as well as in other cases when we need to buy time. We need faster regression of the new vessels when you've got a vitreous hemorrhage, or you've got MVIs, MVGs, or you want to do a vitrectomy, and this helps to regress the new vessels. And of course, we need some longer follow-up to determine what happens in the future, in the long term, but we know that we can cut down the injections with the macular edema, and the same may happen here. It's vote time now for you, but before you vote, I would like you to put yourselves in that man's on the left shoes. He's a pilot, he's a captain. He's trying to land this plane, it's an Airbus, in the middle of the night in a foggy environment. It took him about 30 years to become a pilot and have all this responsibility. He's a diabetic who's got proliferative disease. The scenario is that he was told to choose between the two therapies. If he were in your shoes, would you end up with a field like that, with a laser, or carry on with the anti-VEGFs? You don't have to be a pilot to be logical. Thank you very much.
Okay, we have to repeat the voting now. So, let's put up the question. Again, proliferative diabetic retinopathy with diabetic macular edema. In favor of combined PRP and anti-VEGF injections or anti-VEGF monotherapy. Let's vote now. I don't want to put any pressure on you, but in a couple of days, these guys will be gone, but will still be here. So take that into consideration. Okay, let's finish. Let's see the results. What was the percentage before? 20. Okay, so, but it was like that before, wasn't it?
I still won by miles.
Okay.
I can read percentages, 72, 28.
Well, it hasn't, yeah, but this was before anyway. Anyway, we proceed with the next debate now, the last one. We conclude the